Thank you so much for this opportunity to talk about wAIHA. Warm autoimmune hemolytic anemia is a very important condition that I've learned about over the last 3 years as the global medical affairs leader at Johnson & Johnson Innovative Medicine. Warm autoimmune hemolytic anemia, or wAIHA, is a condition that affects people and destroys red blood cells prematurely. There's no known causative factors, although some people have an underlying condition, such as an autoimmune condition or hematologic malignancy, that is a risk factor. The premature destruction of red blood cells leads to anemia that causes profound symptoms of fatigue, shortness of breath, confusion, and can progress to cardiovascular instability, and also increases the risk of thrombosis. So this is a rare condition, but very serious and potentially life-threatening for individuals who don't respond adequately to treatment. Patients can be diagnosed by going to the hematologist and getting an evaluation of the cause of their anemia, so the low hemoglobin. And during that workup, if it's found that they have signs of red blood cell destruction, hemolysis markers like increased LDH, increased bilirubin, they can receive a DAT test, direct antiglobulin test, that will definitively confirm the presence of a warm autoimmune hemolytic anemia. And let me clarify that it's called warm specifically because the autoantibodies that are causative are best functioning at body temperature. There's other types of hemolytic anemia where the antibodies or complement are optimally functional at colder temperatures. Patients with wAIHA are traditionally managed by starting on high-dose corticosteroids. Depending on the severity, they may need blood transfusions to stabilize their hemoglobin. But the high-dose corticosteroids are one of the most typically used first-line therapies. Also, if patients are severely anemic and hospitalized, physicians may start IVIG, intravenous immunoglobulin, as a way to decrease the autoantibodies quickly. If patients don't respond to those first-line therapies, then often B-cell depleting therapies are tried next as a way to decrease autoantibody production. But those therapies often have 4 to 6 weeks for full response. So that can be a very challenging time for patients. At Johnson & Johnson, we have been conducting a clinical study of Nipocalimab in a phase 2/3 trial that's called Energy. Nipocalimab is an FcRn blocker, meaning that it increases the degradation of antibodies, also decreasing the levels of pathogenic autoantibodies. This compound has been under investigation specifically for patients with wAIHA, and we're very excited to be reaching the final stages of that development program for wAIHA. We have been really looking at wAIHA from multiple different perspectives. Because this rare condition is evolving in understanding, we look at trying to gain more insight into the incidence, prevalence, and clinical characteristics and treatment patterns in different regions. So we've done analysis of that work in Taiwan. And then also looking at what are the impacts of wAIHA in terms of mortality, and presented work from an analysis in Sweden looking at the all-cause mortality of patients, and showed that younger patients did have an increased risk of mortality, a very significant finding. And we're very proud to be looking at wAIHA from multiple different perspectives, not just clinically, but in other meetings, we've looked at the patient perspective because that has been previously underreported. I think the most important thing is to recognize that wAIHA management is not consistent and is not really being adequately addressed across all regions at this time, and that the treatments that are used are leading to unmet need, in whether it's in terms of the mortality, the morbidity, and I think there's an opportunity to look at how the outcomes from conditions are being measured. So we did a systematic literature review and identified a wide variability of outcome measures. So it's very difficult for healthcare practitioners to compare across different investigational studies or retrospective work to be able to make conclusions about the efficacy of treatments relative to each other. I think the one thing that I would like to reinforce is that as there has been more understanding of the real world impact of wAIHA, and we've understood the patient perspective and also the unmet needs from the clinician perspective, we look forward to advancing meaningful research that can, in a targeted manner, address the unmet need for patients with wAIHA.